Good day, everyone who are able to make time to join the CME today. My name is Jong Suli. Today, I am going to present the review of superior vena cava and central venous catheter placement. Topic mainly focusing on persistent left-sided SVC, duplicated SVC, and approach to a misplaced central venous catheter. Objectives for the presentation today include revising anatomy of superior vena cava and its congenital anomalies, classify congenital venous anomalies of thorax, imaging modalities for evaluation of superior vena cava, identify possible malpositioned central venous catheter from frontal radiographs immediately post-insertion, and finally, approach left paramediastinal catheter position with composure. We have a patient, Mr. PW, a 27-year-old male with underlying end-stage renal failure on regular hemodialysis, initially via the right AVF, presented with a right AVF swelling for 1 week. Ultrasound Doppler noted pseudoaneurysm of the right AVF. Subsequently, medical team inserted a left internal jugular vein catheter for hemodialysis. Post-insertion chest X-ray noted left internal jugular catheter is not in the right atrium. Echo also shows that the left IJC is not in the right atrium and not in the cardiac region as well. Blood gas sample from the IJC shows venous sample. This chest X-ray, done on the 5th of April, shows a central venous catheter traversing the right internal jugular vein with the tip well placed about 4 cm below the carina. 4 cm below the carina. And the second radiograph is the post-left IJC insertion radiograph on the 19th of May. Shows that there is left paramediastinal position of the catheter, tip parallel to the descending thoracic aorta. Subsequently, CT thorax was requested to rule out left atrial puncture or puncture of an aberrant vessel. A CT was done for the patient. On plain study, it can be seen that the central venous catheter traversing the left internal jugular vein, lateral to the aortic arch, with the tip within the coronary sinus. This also can be seen on coronal reformatted images. The tip is within the coronary sinus. A right superior vena cava can also be seen in this patient here, and as you follow the left-sided superior vena cava, you can see that there is a bridging vein which likely arises from the left brachiocephalic vein, which drains also into the right superior vena cava. Otherwise, no hemo or pneumomediastinum, hemo or pneumopericardium or pneumothorax in this patient. So there are a few differentials when there is left paramediastinal catheter position on frontal radiograph. If the blood sample returns as venous sample, these are the differentials: persistent left-sided SVC, or catheterization of a tributary of the superior vena cava, for example, internal thoracic vein, superior intercostal vein, or a pericardial phrenic vein, or catheterization of a partial anomalous pulmonary venous return, or it could be located within an artery, or extravascular position, for example, within the mediastinal or pleural space. Just to introduce to everyone, there is a classification of the congenital venous anomaly of thorax. It can be divided into systemic or pulmonary circulation. We are not going to talk about the pulmonary circulation today, and mainly focusing on systemic and the superior vena cava. We are not going to discuss about the azygous system as well. So the congenital anomaly related to superior vena cava include left persistent superior vena cava, duplicated superior vena cava, as well as isolated anomalies related to the right-sided superior vena cava, which is rare, and we are not going to discuss about this today. This figure is just to list out the anomalies that I have mentioned earlier for your reading another day. So, anatomy of the superior vena cava. As we all know, superior vena cava is formed as a confluence of right and left brachiocephalic veins on the right side of superior mediastinum at the level of first costal cartilage. It carries deoxygenated blood from upper half of body to right atrium. Congenital variants of the superior vena cava may be incidental, associated with cardiac anomalies or syndromes. Ultrasound Doppler assessment of the superior vena cava is limited due to poor acoustic window from the overlying ribs or the overlying lungs. Direct visualization of the superior vena cava is better obtained at CT or MR imaging. This is just a CT image of the superior vena cava showing a left brachiocephalic vein and right brachiocephalic vein confluent to form the superior vena cava on the right side of superior mediastinum. So on the frontal radiograph, the superior vena cava forms an interface along the upper right mediastinal border that fades above the medial end of the clavicle. Widening of this space suggests SVC dilatation or a mediastinal mass at this location, for example, lymphadenopathy, bronchogenic cysts, or malignancy arising from the lung, pleura, or trachea. Generally, the recommended position to place the tip of the central venous catheter within the superior vena cava is at 2 cm from the cavo-atrial junction to avoid cardiac perforation, arrhythmias, and catheter-induced thrombus formation. Anatomical landmark for positioning of an upper extremity placed central venous catheter is at about 4 cm below the level of carina. And you can appreciate from this frontal radiograph, the tip of the catheter is at about 4 cm below the level of carina. CT protocol to evaluate the superior vena cava can be obtained with routine contrast-enhanced CT thorax, which is acquired at about 60 to 75 seconds after injecting contrast agent into a peripheral vein. And this is able to achieve excellent uniform enhancement of the superior vena cava. CTA thorax or CTPA or CTA coronary arteries is suboptimal for assessment of the superior vena cava due to strict artifacts from dense contrast material in the superior vena cava and mixing artifacts due to non-enhanced blood from contralateral veins and also the azygous vein, which can mimic a thrombus. And this artifact is well demonstrated in this picture, which shows an early venous phase image and adjacent filling defects seen here. However, if we do a delayed phase image obtained at 75 seconds post contrast injection, there is homogeneous enhancement of the superior vena cava, and the filling defect, which is caused by the mixing artifact, is no longer seen. MRV is not routinely performed in our center, but just for knowledge, MRV can be used to evaluate the superior vena cava as well. It includes an initial first pass contrast enhanced MR angiography followed by a high resolution free breathing, ECG and respiratory gated steady-state MR angiography with use of a navigator sequence. Our MR do not have a ECG gated sequence available, just for information. So knowledge of the embryology of superior vena cava helps in understanding congenital malformation related to superior vena cava. In 5th week of fetal life, there are 3 paired veins, cardinal veins, draining the body of the embryo. So the anterior cardinal veins drain the cephalic portion of the embryo, whereas the posterior cardinal veins drain the caudal portion of the embryo. And these veins will drain into the short paired common cardinal veins and finally draining into the sinus venosus. Formation of the vena cava system is characterized by appearance of anastomosis between the left and right side, so that the blood from left side is directed to the right side. The proximal right anterior cardinal vein, the right common cardinal vein, and also the right horn of sinus venosus forms the normally positioned superior vena cava on the right side of medial mediastinum. The right posterior cardinal vein forms part of the azygous venous system. Part of left anterior cardinal vein forms the left superior intercostal vein as well as the adjacent left brachiocephalic vein, as you can see in this picture. The rest of the left anterior cardinal vein regresses to form the ligament of Marshall. The posterior cardinal vein on the left side regresses, and the left horn of sinus venosus forms the coronary sinus. Left-sided superior vena cava forms due to persistent left anterior cardinal vein, left common cardinal vein, and left horn of sinus venosus during normal fetal development. Persistent left superior vena cava passes anterior to the hilum, anterior to the left hilum, lateral to the aortic arch before joining the circulatory system. Left-sided superior vena cava is seen in about 0.3 to 0.5% of normal population and in about 5% of those with congenital heart disease. Left-sided superior vena cava is only seen in isolation in 10% of cases. Majority are accompanied by a normal right-sided superior vena cava, which is then termed as SVC duplication. Clinically, majority of these patients are asymptomatic and only incidentally identified during a CT scan of the chest or as a result of a line placement like in our patient. 8% of this patient has a right to left shunt as a result of drainage directly into the left atrium. But this is usually not significant enough to cause cyanosis, since this vein is only draining the left upper limb and the left side of the head and neck. Rarely it can lead to systemic embolization, with the patient presenting with symptoms of stroke and brain abscesses. Cardiac arrhythmia can be atrial or ventricular fibrillation, has also been reported as a result of dilated coronary sinus, especially with an absent right superior vena cava, cause stretching of the AV node as well as the bundle of His. Drainage of a left-sided superior vena cava is mainly into the coronary sinus, 92%. It is functionally insignificant since the venous return is from the head and neck and also the ipsilateral upper limb, delivering into the right atrium. 8% is directly delivered into the left atrium, which results in a right to left shunt, but this is usually not large enough to cause cyanosis or symptoms. Placement of a central venous catheter in a left-sided superior vena cava can be mistaken as arterial, mediastinal or pleural placement on frontal radiograph. In up to 90% of cases, persistent left superior vena cava is accompanied by a right superior vena cava, and this is known as duplicated or double superior vena cava. 65% of cases have a double superior vena cava running along each side of mediastinal without any interconnection. However, occasionally there could be a left brachiocephalic vein which connects the duplicated or double superior vena cava, and this is also known as the bridging vein. So in this patient, we can see that there is a persistent left superior vena cava which is small, and this is a similar size and duplicated superior vena cava, and this patient has a persistent but isolated left-sided superior vena cava. And in picture D and E, there is a bridging vein which can be prominent like in picture D or not very prominent in like picture E. And this finding is also seen in our patient. Sometimes these superior vena cava related anomalies can be associated with a list of cardiac anomalies, which I will show here. Sometimes it can also be associated with heterotaxy syndromes. In about 50 to 70% of cases with heterotaxy, there is persistent left superior vena cava. And in half of these patients with heterotaxy, this patient also have double superior vena cava. Just a recap, what is a heterotaxy syndrome? It can be divided into left and right isomerism. Left isomerism, also known as a polysplenia syndrome. Right isomerism, also known as asplenia syndrome. And this is just to show you a radiograph of a patient with a flipped liver but a normal left-sided heart. And this is another patient with heterotaxy syndrome, a patient with situs ambiguous with left isomerism. Patient has a polysplenia with no dominant spleen on the right side, midline located liver, and also not shown in this picture, patient also has azygous continuation of the inferior vena cava. General consideration when you have a frontal radiograph showing a left paramediastinal position of catheter. Again, I'm going to bring up this slide. Located within a vein or artery or is not within any vessel. So this is just few images to show a post-catheter radiograph in a 46-year-old woman showing that there is a left paramediastinal position of catheter which with a catheter tip curved slightly like this, and the differential of this radiograph is include catheterization of a pericardial phrenic vein or extravascular mediastinal soft tissue location or catheterization of a left internal mammary vein. So this patient proceed with a CT scan shows the tip is within the left internal mammary vein. So on frontal radiograph, if there is catheterization of a left internal mammary vein, usually there is this characteristic curve or notch as shown in this radiograph. This is another radiograph showing left paramediastinal position of catheter within the left hemithorax, lateral to the left mediastinal margin, and proceed with CT, which shows intrathoracic tract of the catheter just behind the clavicle, and this is within the internal mammary vein as shown in this schematic diagram. Another frontal radiograph post-catheter insertion showing left paramediastinal position of the central venous catheter, and patient proceed with CT, which shows the course of the central venous catheter descending via the internal jugular vein on the left side, crossing the left brachiocephalic vein, and then descend through the left pericardial phrenic vein, and they concluded this as a left pericardial phrenic vein catheterization. The danger about left pericardial phrenic vein catheterization is that it can migrate into the pericardial space, resulting in cardiac tamponade when you start to administer fluid and the fluid goes into the pericardium. So the use of central venous catheter in this placement should be postponed until a frontal radiograph has documented a correct placement. And this is another radiograph of a patient post-catheterization via the left internal jugular vein, and proceed with venogram showing that there is a catheterization of a left-sided partial anomalous pulmonary venous return. Finally, another patient post-catheterization shows left paramediastinal position, but this catheter is not parallel to the descending thoracic aorta, rather the tip is within the descending thoracic aorta, or possibly the ascending thoracic aorta. Proceed with CT shows the tip of the catheter is within the ascending aorta. And this is a very nice 3D reconstructed images from the CT examination showing the tip of the catheter is located within the ascending aorta. And this is everyone's nightmare. So to end my presentation, generally, central venous catheter should be placed at the junction of the superior vena cava and right atrium, which lies at about 4 cm below the level of carina on frontal radiograph. If the catheter is positioned in a left paramediastinal position on frontal radiograph, do not panic, as the catheter is most likely within an anomalous vein, unless the post-catheterization radiograph shows development of a pneumomediastinum or pericardium or pneumothorax, or the blood gas return as arterial. Findings of a dilated right heart chamber with no evidence of atrial septal defect or dilated coronary sinus on cross-sectional imaging should raise suspicion of a persistent left-sided superior vena cava. And if in doubt, cross-sectional imaging is available and can help to confirm catheter position. That's all for my presentation today. Remember to keep calm and breathe deeply. Thank you, and these are my references.